All right. Good morning, ladies and gentlemen. It's great to have you all here. Welcome to the Salem Chamber Forum Speaker Series presented by our partners at Hagen Hamilton Insurance. If you could silence your cell phones, that would be appreciated by your fellow guests. We've got a great program today. Join me in welcoming Salem Chamber President, Mr. Alan Rasmussen.
Well, good afternoon to our Salem Chamber membership. Can't quite believe it's March already. 2024 is flying by. I don't know that we would know that it's March with the weather the last 4 or 5 days, but looking forward to the rest of the year here with the Chamber. Quite a few exciting events coming up that I'll touch on here at the end. It's wonderful for you. It's wonderful to gather with you this morning. We have a great topic affecting each of us, no matter our stage in life or current health condition. We know there are few industries that have faced more complexities, government oversight, or more demands from the public than they deserve than those in healthcare. Today, we'll hear an important voice in the national healthcare space from Dr. John Coombs. Today's luncheon sponsor is Salem Health and the Salem Health Foundation. Thank you to our past president, Jim Bauer. Our season-long presenting sponsor is our partners at Hagen Hamilton Insurance Solutions. At this time, would you please stand with me for a moment of reflection or prayer, and then followed by that, a presentation of our national anthem performed today by Sarah Mutinelli. We take this moment to pray or reflect, each in our own way, on our lives and on this moment. We are thankful for the meal before us, for the hands that prepared it, and for those who serve it. We are grateful for this day, for its blessings, its opportunities, and even for its challenges. May we lend each other strength and guidance as fellow leaders here within the Salem community. May we be deeply driven to give our best always and be so courageous to rise to meet the challenges we face. Amen. Sarah, would you kindly perform our national anthem?
Oh, say, can you see by the dawn's early light what so proudly we hailed at the twilight's last gleaming, whose broad stripes and bright stars through the perilous fight, o'er the ramparts we watched, were so gallantly streaming, and the rocket's red glare, the bombs bursting in air, gave proof through the night that our flag was still there. Oh, say, does that star-spangled banner yet wave o'er the land of the free and the home of the brave?
Well, thank you, Sarah, for presenting the national anthem this morning. Sarah is the owner and director of Young Singers Club of Salem. Sarah is spreading the joy of music with young people across our community. See what impact she is having locally at salemyoungsingersclub.com. That's salemyoungsingersclub.com. Well, today I'm joined by 5 peers here at the head table. They include our esteemed speaker, Dr. John Coombs, President and CEO of Salem Health, registered nurse Cheryl Nestor-Wolf, Chief Development Director of the Salem Health Foundation and Salem's Chamber past President Jim Bauer, benefits consultant Matt Houston from our presenting sponsors at Hagen Hamilton Insurance Solutions, and the Salem Chamber's own Director of Business Advocacy, Lena Prine. Join me in welcoming our head table today. It's now my honor to introduce our dignitaries in attendance today, our elected officials, past presidents, and board of directors. Our elected officials today, Sarita Cross, Kaiser City Council. Julie Hoy, Salem City Council. Steve Horning, Turner Mayor. Colm Willis, Marion County Commissioner. And Craig Pope, Polk County Commissioner. I'll read off a list of my colleagues of past presidents and chamber board directors, and we'll give them applause here at the end. Our chamber past presidents, Laura Dorn, Barb Hack-Resch, Jim Bauer, John Miller, Brent D. Hart, TJ Sullivan, Ryan Albritton, and Kathy Gordon. And then current board members that I serve with, Rich Duncan, Ted Ferry, Laura Dorn, Roger Hoy, Brandon Blair, Ryan Dempster, Mike Herron, Kathy Gordon, and Jim Vu. Well, we are very pleased to have the experts at Hagen Hamilton Insurance Solutions presenting the 2023-24 Forum Speakers Series each month. Since 1910, Hagen Hamilton has been insuring people and businesses across the Pacific Northwest, all while staying true to their mission and values. To share a bit about Hagen Hamilton Insurance Solutions, please welcome their benefits consultant, Matt Houston.
Hello, everybody. Nice seeing you again. As Chuck said, Alan. Last time I was up here, of course, it was Matt Huston instead of Houston, so had to rib him a little bit for that. But thanks so much for having us up here. It's been an absolute pleasure to be the primary sponsor for all of this. I'm excited because a couple months ago, I stood up here and kind of told you all about something that had happened for Hagen Hamilton for 14 straight years. And that's that we'd been voted one of the top 100 companies to work for. And again, not many companies can say 14 years, let alone 14 in a row. At that time, I said the tally wasn't in yet. We didn't know if we made it yet for the 15th year. And so I get to tell y'all we did. So for 15 straight years, yeah, please. So that's a huge honor, something that we are very, very proud of and something that we really take great pride in. Today I want to talk about the individuals we have here with Hagen Hamilton for us. Mr. Chris McLaren, Stephanie Kemp, Beth Black, Chad Neal, and TJ Sullivan, representing you all here in Salem and whatever we can do. One last piece that Hagen Hamilton is growing. We will be opening and are opening a new branch. This will be our 7th branch, and it's down in Corvallis. So we are, as always looking for new ways to grow, to serve you all, and we're so happy that Salem is the hub of that. So with that, I'm going to now introduce actually the CEO of the Salem Chamber, Tom, invite him up to share some exciting news that's going on amongst the chamber and your programs.
Thanks so much, Matt. Thank you. Appreciate that. Well, it is a distinct pleasure, first of all, to have a young lady who we're very excited about joining our Salem Chamber staff. Please stand up and give a wave, and that is Maddie Melgard. I'm looking in back. There she is. Maddie Melgard is we're very pleased to bring Maddie on the Salem Chamber team as our events and programming manager. And with all great things and great partnerships, sometimes things go for a change. I have had the pleasure of working with a very special individual, somebody that I put in the absolute highest regards for her professionalism and the work she has done for this community. And our own Lena Prine will be transitioning to a new role with a local lobbying firm, really following her passions as she goes to the next stage of her professional career working with the PAC West lobby team. Lena's impact within this organization has been very profound, and if you have watched any of our business advocacy publications, the engagement that we've done within our membership to bring people to the table and have their voice heard. Undoubtedly, Lena has been a big part of conveying that message. While we are going to certainly miss Lena, and we do intend to have her give you a brief update as well as introduce Cheryl Nestor-Wolf today, I would like you to join me in saluting Lena for an incredible career at the Salem Chamber.
Thanks, that was very kind and surprising. I'm happy to have the chance to stand in front of you and invite you to a couple of really exciting events that we have coming up. Tomorrow night, we're having our first legislative reception. Hopefully, it'll be our first annual legislative reception. We've invited our local Salem area state representatives and state senators, as well as leadership, to join us in the room. And we've just learned this morning that there are no evening committee hearings and no evening floor tomorrow night, so we're thrilled about that news. But as a business community, we encourage you to join us tomorrow night between 4:30 and 6 p.m. at the Salem Chamber offices. Come and have a hosted beverage and hors d'oeuvre and mingle and visit with your elected officials in our area. So again, that's tomorrow night, Tuesday, March 5th from 4:30 to 6. And then in response to the terrific contractors forum that we had in January, we invite you to join us for an overview of navigating Oregon buys. We have an Oregon buys workshop on Wednesday, March 13th at 9 a.m. to 10:30, also at our Salem Chamber offices. Attendees will receive an overview on how to search and respond to solicitations, getting your community code profile dialed in for receiving notice of opportunities that align with products and services. So again, that's the Oregon Buys Workshop on March 13th at 9. Now, to present a formal introduction of our keynote speaker, it is my pleasure to introduce Cheryl Nestor-Wolf, registered nurse and president and CEO of Salem Health. Ms. Nestor-Wolf came to Salem Health in 2007, serving as the Senior Vice President of Operations and Chief Nursing Officer. In 2010, Cheryl was promoted to Chief Operating Officer and took the helm of Salem Health when she was appointed President and CEO in 2015. Cheryl leads a dynamic team of medical doctors, nurses, and professional support staff. Salem Health, serving as today's monthly sponsor, is an invaluable community partner and advocate. Ladies and gentlemen, join me in welcoming Salem Health's President and CEO, Cheryl Nestor-Wolf.
So I want to thank you and just say that I'm really happy to be with you today, but also with you since 2007, and to introduce today's speaker, Dr. John Combs. Before I tell you a little bit about Dr. Combs, first let me say thank you for the work you do every day to create vitality in our community. I want to recognize the hard work it takes to keep your businesses strong and creates our outstanding communities. As I think about what the Mid-Valley looks like 20 years from now, I believe exceptional health care is essential. It is foundational to a thriving economy and livable communities. Our healthcare infrastructure excuse me, was built on the work of citizen leaders over 125 years ago. With great foresight, they spent their time and effort attracting doctors and trained professionals into our area and creating an exceptional place for them to give care. Some things haven't changed in 125 years. Salem Health Hospitals and Clinics has volunteer board members, trustees members, of which 11 of the 14 are from the Mid-Willamette Valley. This means your regional health system is locally controlled and strives to remain essential. The board continues to assure the essentiality of healthcare services in Marion and Polk County for 125 more years, adhering to our mission to improve the health and well-being of the people and the community we serve. Our population is steadily increasing and aging. Patients need more care, and their conditions are increasing in complexity. Salem Health Hospitals and Clinics strives to build a model of care that grows with the healthcare needs of our community. We foster a strong and committed workforce. We continue to supply better facilities and services, and we regularly add and update technology and equipment. This introduction brings me to introduce Dr. John Combs, who is the chair of Salem Health's Volunteer Board of Directors. He brings a unique perspective on how communities can protect and expand access to health care. Dr. Combs writes and speaks often on healthcare governance, physician issues, quality, and best practices of healthcare leadership. Dr. Combs is the retired Chief Medical Officer and Senior Vice President of the American Hospital Association and a past president of the Center of Healthcare Governance. His specialty areas of expertise include medical quality, healthcare governance, physician leadership, clinical integration, patient safety, and palliative care. Dr. Combs is presently responsible for leading all external and internal communications, public and media releases, as well as policy development, regulatory, and legislative relationships for the Accreditation Council for Graduate Medical Education. Today, Dr. Combs will share the challenges on the horizon, the local implications for what is happening at the national level, and what we should do to preserve our locally controlled and operated regional health system. Please join me in welcoming Dr. Combs to the podium.
Thank you so much, Cheryl, and good afternoon, everyone. And I also want to thank you for welcoming me with a bit of Chicago weather. Although Chicago's been having what weather you're supposed to have, because we're in the 50s and 60s these days, so thank you for that as well. What I'm going to speak to you about today is developing a community-centered healthcare system. But I'm going to get to that by starting with what's really going on in the national environment and how that relates to Salem Health. I don't know how many of you are watchers of Law and Order, but you know it starts with ripped from the headlines. And I'm going to start with ripped from the headlines for you. You have seen that recently in the past year, Kaiser Permanente has agreed to acquire Geisinger and form another company called Risient to acquire more healthcare systems around the country. So we're talking about a very large system that will be controlling a lot of local care in various communities around the country. And locally, we've seen in Portland the move to have OHSU merge with struggling Legacy Health, as the headline in the Oregon Live, the Oregonian, was a couple of weeks ago. Why is everyone doing this? Why is there this rush to create these mega systems that get more and more distance from the local communities that are receiving the care? Well, back in 2016, the ACGME started to look at their sponsoring institutions. Those are the institutions that sponsor residency and fellowship programs. They are mostly hospitals and health systems. And we wanted to know the state of those hospitals and health systems, so went out and interviewed CEOs across the country. From their impressions of what was happening in healthcare, we divided them into three sort of mega trends that were going on. One was democratization of healthcare, the other was commoditization of healthcare, and then finally corporatization of healthcare. So what did that look like? Well, in democratization, you all know that you can get information anywhere these days. 30 years ago, if you wanted to know about a health condition, you had to speak to a doctor, and sometimes a nurse would have those answers. But you certainly couldn't look on your phone and get the answer to your question immediately, which is what's happened now. You also had to wait for appointments. You had to schedule exams. Today, you can walk into your local drugstore and get an exam, can get a vaccination, can get a prescription from your pharmacist for a variety of medications. COVID taught us all that we can test for conditions at home. We had to. And that has continued on. So home testing for a lot of conditions and immediate results of laboratory studies. For those of you as old as I am, remember waiting weeks to get back a CBC, a complete blood count. And so healthcare has really become more of a democratic process than it has ever been in the past. And finally, we all wear these devices that tell us the status of our health immediately, whether we're exercising enough or not exercising enough. Some of us, it tells us what our blood sugar is, what our blood pressure is, whether or not we're in atrial fibrillation on our watch. All of that leads to people having much more control over their health conditions. Commoditization. There is a price war, believe it or not necessarily between hospitals in a local locality, but between countries. I was recently in Jordan, and when we landed at the airport, there was a whole special terminal for people who were engaged in medical tourism, that they were going to the Jordanian hospitals for surgeries, basically based on price. And again, we're seeing that all over with a variety of different conditions, including joint replacements and cataract surgery. And then finally is the topic I want to talk about. Is corporatization. Why the growth of these mega health systems? What's happening that's causing this, and how does it impact us as consumers of healthcare and as patients of some of these very large systems? Recently, the American Hospital Association put out an infographic on the growth of healthcare systems in the United States. There's 67% of all hospitals now in the United States are in health systems. 76% of all beds, hospital beds, belong to health systems. But they're not all mega health systems. In fact, 56% of them have less than 1,000 beds within their system, and 2% of them are the real large systems with more than 100 beds. They reckon that the number of health systems is 407. But I have to tell you that number is a little bit suspect. There's lots of different ways to characterize them, and I've seen numbers as high as 600 health systems within the United States. But those systems have been evolving for quite some time. Back in the 1940s, the only large healthcare systems were the Catholic systems, mainly because they were run by orders of nuns who settled all throughout states and linked up all their healthcare systems. But people learned from that, and beginning in the 80s, we saw the rise of investor-owned hospitals and healthcare systems. And then through the 90s, we've seen a big growth in healthcare systems. Prior to the pandemic, we were really on a growth curve, which stopped during the pandemic, but then has picked up again. So hospital care is now concentrated in these systems. Most of them are, or at least half of them, are rather small systems that have 1 to 5 hospitals. And there are others that are very large, but they are a very small number, about 7%. But we're seeing more and more of a growth in that direction. As you can see, most of the hospital beds are in systems, and most of the hospitals are currently in systems. That growth began back, before 2000, but you can see this growth curve up to 2017, and I have to tell you that's continued to grow. I think this peaked out at about 3,500 hospitals that were in systems, and now we're in over 4,000 hospitals that are in system. And the number of independent freestanding hospitals has decreased tremendously over that period of time. So what was the drivers of all of this? Well, access to capital was the major driver. There was legislation back in the 40s and 50s that allowed communities to build hospitals. And that's why we have so many hospitals that date from the early 50s and 40s. Well, as you can imagine, 50 years later, in 2000, many of those hospitals needed to be replaced and needed an infusion of capital. And many of them turned to larger systems near them to get that kind of investment to improve those facilities. And that has led to some systems acquiring those hospitals, but then replacing those hospitals with either clinics or a very limited service hospitals. So we've seen that as a way that smaller hospitals that needed capital joined up with a system to acquire and access some of that capital. But then when the decision is moved to the larger system, you may have a change in the nature of the healthcare facility in that community. There's also a need for these systems to have a bigger footprint in their community to attract more patients and more business. So there's those larger systems would have a greater relevance in those communities. There was also a need for more expertise in management and in systems planning and information technology. And the larger the system, the better they could access some of that talent. There was a claim to get to more economies of scale by having these larger systems and more ability to access, which was a very expensive investment, the conversion of our paper records to electronic records, a conversion of our scheduling from hand scheduling to electronic scheduling, and really the movement into the electronic and information technology age. And so many hospitals found themselves very short of capital to do that and had to turn to neighbors to help them. And then finally, these larger systems wanted to capture population so that they could begin to do more population-based health improvement, health management, and be involved in more what we call value-based care, where they are at risk for the population with a capitated or per head payment by an insurance company and begin to manage that population that they acquired. You can't do that with a limited number of people. It has to be a large population. So that was another driver for consolidation. When we look at what has happened over the past year or so, this trend has continued. 65 hospital and health system deals were announced in 2023 with an average of transaction amount of about $38.4 billion. And the average size of the deal measured by the smaller hospital was about $591 million. And that's a cutback from 2022, but really much higher than what was happening pre-pandemic. So this trend is continuing, and hospitals are continuing to build large networks. And when you look at the evolution over time, this has started a lot with local hospital mergers, and then a move into regional systems, so that in Portland you can talk about the regional system, but you also have very large national players there as well that are trying to create even greater systems, which leads us to cross-market consolidation is what you would see in something like a Providence Health System, which has a market here in Portland and Washington, but also in California as well. And I'll show you some examples of some markets that are not even close to each other in terms of the region of the country going forward. What the hope of all of this was to get to a level of clinical integration, being able to seamlessly move a patient through a system, through their registration, to their treatment, to their follow-up, all in a seamless way. One of the past CEOs of the AHA expressed it this way: you get to that system integration when you can say you have one registration, one medical record, and one bill. And that's when you know that you may be on the road to clinical integration. But when you look at some of these larger systems, they're still in this state of asset aggregation, having these individual units that are not necessarily working with each other to improve the care of the patient across the system. And that's the challenge right now. How do you take these large organizations and make sure that that patient has that seamless level of care throughout the entire organization? And that brings you to the last column on the right there of system optimization, when you really are transforming the delivery of care. And I have to say, in looking at all this activity on the financial side, all this M&A activity, have we really seen a transformation of care in a lot of these systems, and how patients experience it and how they deal with their illnesses? The new move is really to these cross-market consolidations. And one that was announced that really affects the whole middle of the country and has gone through was the Intermountain Sisters of Charity of Leavenworth merger. If you look at that map, those are all the mountain states now that are in one healthcare system. Intermountain itself was a very large system, and the Sisters of Charity of Fort Leavenworth were centered around Denver and south and over to the east of that. In our own region in Chicago, Advocate, which was a small system with a couple of hospitals and good physician integration, then merged with a physician-led system in Milwaukee and became Advocate Aurora, and is now merged with Atrium Health, which was the old Carolinas Healthcare. One wonders, how do you get to efficiencies? How do you get to leverage when you're in the markets that distance? And we don't know the answer to that. It's yet to be shown. And then one that didn't happen, mainly because the FTC is looking at these much more closely than they were in the past, was the Sanford Health and Fairview in Minneapolis. And that would have been a large segment of the Midwest in that system. But it's still going on. We have in 2023 announcements by BJC Healthcare and Kaiser Permanente of the large mergers. I mentioned the Kaiser one earlier, and their goal really to create a new company that would acquire even more community-based systems or hospitals and fold them into this network. BJC and St. Luke's Health System really cover the whole state of Missouri. St. Luke's is based in Kansas City, they're based in St. Louis, and so you're gonna have a large statewide system that will begin to try to manage the care throughout that state. And then one that has failed, again, because of the concern about FTC scrutiny, was Presbyterian in Albuquerque and Unity Point Health in Iowa. But if you look at the map and where this is all occurring, you're pretty far advanced here in Oregon. Over 70% of the hospitals in Oregon are already in systems. And there are about now 22 systems. This map is a little bit older. But if you look at the concentration of healthcare systems, they're on the East Coast and the West Coast. But you have really taken the lead on the West Coast in Oregon. So talking about Salem, which we'll get to in a minute, is a little bit of an anomaly. So what are the large not-for-profit health systems in the United States? You can see from this there are 10 that really are really remarkable for their size and their scope, beginning with a Catholic Health System, Ascension, and running all the way down to one second. All the way down to the Mayo Clinic, which is a very well-known system, but now is in Arizona and Florida as well. But look at you and your markets. You have Providence and you have Kaiser. So 2 of the top 10 health systems are in your state already and directing a lot of the care within those states. You have Providence based in Renton, Washington, and Kaiser in Oakland, California. Those are the systems that are making decisions for the communities here in Oregon. So what are the benefits of the consolidation? I will tell you the source of this is from my old employer, the American Hospital Association, so you'll see that it might be a little bit on the positive side. So continued access for the local community so that those facilities don't go away. That access to capital that we talked about earlier. There may be a slight reduction in mortality rates and operating expenses in the acquired organization. And then there may be some evidence of some decreased mortalities, particularly in rural hospitals. But there's also challenges associated with consolidation. And a lot of this comes from a Kaiser Family Foundation report that was published in Health Affairs. There's also a New England Journal article in 2020 looking at quality and consolidation. And there was really no measurable impact on improving quality by creating these very large systems. There was some decrease in patient experience in navigating those systems. No decrease in cost, but there may well have been increases in prices in a lot of the acquired hospitals, as well as of interest, the surrounding hospitals of those that were acquired in that community. And then I think the really biggest negative is the centralized decision-making. The community loses control of whether or not they're going to have an acute care hospital anymore, or they're going to have a health station, or they're going to have a freestanding emergency room. It all depends on what effect it has on the overall healthcare corporation. So how about Salem Health here in Salem? Well, we are a system too, so I'm not going to talk about the negatives of being a system, because there are a lot of positives to it. But it really depends on what kind of system you are. So Salem has 2 hospitals. One is a critical access hospital that I think you all know in the West Valley, and one right here in Salem. The one in Salem is the largest in the state in terms of bed size. It has one of the busiest emergency rooms on the West Coast. It has 9 primary care clinics distributed throughout Marion and Polk counties. And we are a community-based system, and we've been around for 127 years. So almost as long as the founding of Salem itself. So this is a system that's here and been here and continues to stay here. It's a comprehensive system. Not only do you have that acute care hospital, but you have a critical access hospital that in Dallas that I referenced earlier. That critical access hospital has been really a focus of major improvements over the last year or so in terms of being incorporated into the system of care that has been developed at Salem. It's also been expanded from 6 beds to 25 beds, and those beds are now swing beds. They can be used both as acute care beds, and they can be used for ongoing care and intermediate care for patients. We have over 900 providers. Those are both physicians and nurse practitioners and physician assistants. We do a large number, as you can see, of diagnostic procedures, of laboratory procedures, and surgeries. And again, as I referenced earlier, that ED, and we have the former head of the ED with us today, and can attest to it, is one of the busiest on the west coast of the United States. And this is a full range of quality services. And why do I say they're quality services? Because they've been recognized nationally by several different organizations. I think one of the ones we're most proud of is the Magnet recognition. This is a nursing recognition for the best nursing care, the most organized nursing care with some of the best outcomes. It is a very difficult recognition to get, and I think we're working on our fourth one, aren't we, Sarah, right now? They have been recognized 3 times for this already for outstanding nursing care. We have centers of excellence represented by our accreditor in spine, in joint replacement, in breast imaging. We have a recognized breast center and a cancer center, and we are a level 2 trauma center here in Salem and a level 4 trauma center in Dallas. So this is a system that is really focused on quality and keeping quality here in the community. And if you look at our journey to system optimization, we are really moving into that last column, as I talked about earlier. We are transforming care at the bedside, and I'll talk a little bit about how we're doing that. We have an excellent IT system with decision support and are probably implementing shortly some artificial intelligence to help with that as well. We are focused on performance improvement and clinical integration through our medical group and our really good, strong relationships with even the community-based physicians. How do we hope to get to that last column? And it's really our organizational principles. For those of you in the manufacturing industry here and some of the service industries, you must have all know about lean, and I'm sure some of you are lean organizations. We are a tremendously lean-driven organization. In fact, we've driven lean to the front lines. We've empowered our employees not only to be observers of things that are wasteful, that don't add value to the care of the patient, but we also empowered them to come up with solutions, to develop the first solutions and test them out, and then eventually make them the way we do business. We're also trying to become a highly reliable organization. Those are the organizations like nuclear power, part of the military, where you have a potential for disaster, and what you do is develop the capacity called mindfulness to anticipate that potential and then to be able to respond to it, to develop the resilience to respond to it. So there's a preoccupation with failure in those organizations. There's a sensitivity to operations that we always follow standard operating procedures. But then when something goes wrong, there's a bounce back, a resilience, and that we defer to the expertise, whether that's a frontline nurse or the chief of surgery. It's the person with the most information about the situation that takes the leadership role. And we're developing that culture within Salem and based on mutual respect and understanding of everyone's roles. And all of this is driven by a robust set of quality metrics that we monitor constantly. Becoming a clinically integrated organization also requires a strong partnership with our physicians and other providers of care in the organization. Currently, Salem has 231 providers that are Salem employees that work with Salem. As I said, there are 9 primary care centers and 2 urgent care centers. There are very specialty centers that are being developed in cancer, OBGYN, cardiology, and orthopedics. In fact, recently, our orthopedics physicians asked to become employees of Salem and are now fully integrated into Salem. Again, the same medical record, the same bill, the same registration. So they're really becoming part of that integrated system. We have an ambulatory surgery center out of which they operate, and we have that single medical record. But more importantly, we continue to be a community-focused system. We pay attention to accessibility for our system and to affordability. We've done $100 million in charity care in the last fiscal year and continue to focus on making sure we have payment policies that respect the diversity of the economic status of this community and that is approached with care and empathy. We have an understanding about the range of care needed in our local communities because we participate with our community partners in a community health needs assessment every 3 years and use that health needs assessment to develop our strategies for the ensuing years. We have very long-range planning, and you will chuckle at this, but we actually look out 100 years for some of our building programs to see what our needs, the needs of this community, not our needs, the needs of this community is going to be in 100 years. And we base our financial decisions on those needs. Our financial stewardship is based on looking and being flexible about how we can take care of this community and continue to have the resources to take care of this community. So we're very aware of the financial pressures in healthcare, the changing government policies and regulations, the changing reimbursement rates from our insurance partners, so to speak. And we look at those numbers to make sure that we can generate money that we can plow back into this community to continue to care for it. But more importantly, we're grounded in this community, in the Salem area. As Cheryl said before, we have a 13-member board of trustees, but we just don't pick the leading lights of this community. Our board really focuses on a competency-based board. What are the competencies we need to take care of the community? What are the competencies we need to govern Salem? So 11 members of our board, as Cheryl pointed out, are from the Mid-Willamette Valley, and 2 are from outside this region. I'm one of the 2. And that's because the board, I think, was wise enough not to pick me, they could have picked anybody, with a national perspective that could help guide us through this changing landscape that I just outlined. Our second outside member comes with insurance experience and understanding and comes from a large system in California. So we are willing to tap into expertise anywhere to help us, but we would still want to remain grounded here locally. So all our decisions are locally based and reflect those community needs. So in summary, I just want to say, environmental forces, and they are tremendous, and I think you outlined them in the beginning very well. Where is he? Outlined them in the beginning very well, that are affecting healthcare. And they're coming from all sides. And that's driving a lot of this movement to this large hospital consolidation. And the creation of these large systems are moving decision-making away from the local community to places like Oakland and Renton and other centralized areas. And Salem, in spite of all this, is moving to the creation of a community-based integrated system, one that has the benefits of being integrated, of being coordinated, of having one medical record, one billing, and one registration, but in keeping all the decision-making local to best respond to the community needs. In closing, I want to say I've been in healthcare, I hate to say it, for over 40 years, probably more like 45 years, getting close to 50. And I have been at multiple hospitals in the United States. I've been a chief medical officer of a couple of large systems. I trained in a city hospital in Boston. I was at a large academic medical center, Cornell in New York, for my medical school. I traveled all around the country with the American Hospital Association, talking to boards and medical staffs and very small hospitals in Nebraska and in Alaska as well. I've been to all 50 states visiting hospitals. This is the finest hospital I've ever been associated with. You have in your community a jewel. And I'm not just saying that because I'm the chair of the board. I'm saying that from my national perspective and my lifetime experience. You have one of the greatest nursing staffs, one of the greatest physician staffs that are all dedicated to one thing and making sure that the mission of taking care of this community continues into the future and is done with respect and dignity. And we have a fine team of administrative leaders that is carrying that out. And that really begins with Cheryl's. So I want to thank you for the opportunity to speak to you today, and I'd be happy to take any questions. Okay, in the back, there's a couple.
So your perspective, again, I'm glad to hear you have 45 going on 50 years of experience. So you've seen a big evolution in healthcare policy and governance across the country. Clearly there is a major drive for a single payer system across the nation. And Cheryl is probably thinking back how many times I've asked this question, for our Mid-Willamette challenges. I'm very sensitive to the impacts that kind of politics and policy discussion has on a system as fragile as you've described. But what do you think that looks like going forward? Make a prediction, if you would.
Well, it's hard to make a prediction. I went through the whole ACA. I was at the American Hospital Association. We actually polled our CEO members as that discussion was evolving in the late, I don't know what you call them, the aughts, the late, like 2007, 2008. And many of the CEOs voted for a single payer system just because it would be administratively simple. Yes, you'd have one rate setting organization. In Maryland right now has rate setting and has a single payer system basically. Everybody has to pay the same as Medicare. There's a special waiver in Medicare to allow that to happen. And from my understanding is most of the CEOs like that because it does make it administratively simple. You know what the biggest office in a hospital is? The billing office. Because we deal with so many health plans, and a health plan is not a health plan. There's various plans for each employer in those plans with all sorts of different conditions. We have to take care and count for all of that and bill for all of that. It's a tremendous administrative burden and a tremendous cost. So I think if we went to a single payer, and I'm not advocating for it, and we could be able to make sure that it truly accounted for the cost of caring for patients, and more importantly, allowed for innovation so that we could move into new technologies, which are very expensive, and new programs, then I think it could be a system that could work. Again, I don't know, I don't see that happening right away in this country. They've got too many vested interests particularly on the insurance side, And, Medicare was able to get through because it cut a deal with the insurers that they became the fiscal intermediaries. And so I think something like that would have to happen over time. So I don't see that happening, but I do see a rise. I talked about consolidation on the healthcare side. There's also been major consolidation on the payer side as well. So I don't know if I answered your question, but. We could argue. That's all right. I have all afternoon. Yes.
First of all, thank you for flying halfway across the country to visit with us today. A statement and then a question. A month ago, I sought a second opinion at the Mayo Clinic. I was in Rochester, Minnesota, and they didn't change any of the treatment that I received here in Salem. So I think that's a testament to your closing remarks. My question is, I'm curious about trends that you're seeing in physician migration post-COVID. It seems as though there's some sort of a movement that, a shuffling of physicians. And I wonder if that's just an observation or if there are some trends that track that.
No, it's not. COVID actually brought out an issue that we knew about long before COVID and worked on, and I'm happy to say Salem continues to work on that, is clinician burnout. That people are very frustrated by the system, and because of that, their work loses meaning for them. When you're spending more time doing prior authorization than being in a room with the patient, it's very demoralizing for that person, and they begin to burn out. COVID added to that problem because of the moral injury of having limited resources to take care of a lot of sick people. And that has continued afterwards. So what we're seeing is a lot more early retirements, so you're losing health care workers. A lot more people saying, is this worth it? I want to spend more time with my family than actually work in for them, a demoralizing environment. And so that's why we're seeing a shortage of healthcare workers, not just physicians, but nurses, technicians, therapists. And it's really an issue. And the question is, how do we create meaning in work again? And it's something I know in Salem we're working on very carefully. We actually have people on the floors to help with this issue. When you lose a patient or even say commit an error, people take that personally, and it hurts. And it hurts them, maybe not as much as it hurt the patient or hurt the situation, but it hurts. And people eventually burn out from having that happen to them over and over again. And if the system is frustrating because I have this patient here who needs a nursing home bed and there's not enough nursing home beds, and I have to watch them deteriorate here, and rather than being in a place where they need to be, it's really tough. So yes, I don't know that their migration patterns have changed that much. We were very successful, and our administrative staff was very successful to be able to build an anesthesia department when the contracted anesthesiology group pulled out. And we now have a complete anesthesiology department of employees that we were able to attract to Salem. Salem's a very attractive place for people to live and to have a family. So that's helped tremendously. And all your work to help build this community has helped us be able to have the human resources we need to run a healthcare system. And it's sort of a codependency, because that attracts employees for you to make sure that you have a strong healthcare system within your community.
Yes. What is Salem Health, Salem Hospital's next big initiative? What's on the horizon?
Well, we're looking at lots of things. We're always continuing to look at our campus and can we meet the needs of people at our campus? Do we need to look at within the confines of the current campus? I think we have enough land there, but we have buildings that are older that would need to be refurbished. So those are the kinds of things we look at. We just, you might have heard in the news, lost a cardiac thoracic surgeon. So we need to help rebuild that, and we will, just like we rebuilt the anesthesia department, which is almost a world-class anesthesia department now. So those are the kinds of things we consider constantly. Every month I meet with Cheryl before the board meeting, and I say, we have a nice agenda here. It's Wednesday, the board meeting's on Friday. What else is going to come up? And usually something does. And so we continue to respond to that. I think part of it is this lean philosophy we have, that everybody there, including the board members, tend to be problem solvers. If they see an issue, they start to think about solutions and how to implement them and test them. And I think that's the most important thing that our staff does, is that we test things before we make it call standard work. This is the way we're going to work from now on out, because we've tested it as a response to a problem that rose. So I can't specifically tell you the next big thing. Technology always. We're always looking at IT. As I said, the impact of AI, artificial intelligence, on our IT systems, on our decision support systems that help support getting best decisions at the bedside is a big one. And I got to tell you, it's a very expensive one. And I just learned something else too, that it uses a lot of energy. So that's another thing that we'll be facing in the future, and the community will be facing in terms of energy supply and sources of energy that don't damage our environment.
I wonder if you could go back deeper on the billing. I had an opportunity to go back to Washington, D.C. when an oncology doctor invited me back, along with 200 other business people with a bunch of oncologists back there, telling us how about billing. And at the end of the conference, they asked, what did you business people hear about how people get paid for their practices? And at the end, I said, it would be like if I sold this doctor friend of mine a car, I would apply to DEQ for a payment. I mean, it was just absolutely that ridiculous. So what's the answer to the billing process?
Well, part of it is we have a system that is totally irrational. I mean, when you look at it, especially on the business side, we have prices. We don't get paid the prices. Every contract you do, you have to take a discount off that price to get the contract. And usually that discount is anywhere from 50 to 55%. So and then you have to deal with the plan on that, because that becomes now your new base. And the plan may pay, depending on the coverage, 80%, and then you have a copay for 20%, or it could pay 60%. It could pay less. And then somebody else is responsible for the rest of that payment, and it may or may not come. Well, physicians have the same problem, because they operate pretty much the same way. And it's not like I come to you and negotiate a price of a car, even though you have a sticker price. We negotiate a price. I shake your hand, I walk out, I pay that price. You come out of a doctor's office, you may have to put your $20 copay down, but you don't know what the doctor's going to get out of that, because the insurance company could deny part of that, or they could, they may be out of network and they may get less money for that, and you can't balance bill. So it's a system that's crazy, and that's why when you ask the single payer question, there could be a lot, if done correctly, and a lot of this depends on if things are done correctly. We know how often that happens. But if it's done correctly, it could reduce a lot of administrative burden that adds to the cost that it's not going to take care of the patient. And so, at a national level, we have to think about these things. How do we do a better job of using all of this money that goes into this system more efficiently for the care of the patient and better outcomes and better quality?
Well, thank you.
Thank you.
Well, thank you, Dr. Coombs, for sharing your perspectives on national healthcare trends and then the impact here locally at Salem Health. Some that know me, workforce development is a passion of mine, been very plugged in at CTEC. Salem Health does an awesome job over at the Willamette Career Academy on Lancaster. They have an incredible nursing classroom over there, so I encourage you to go check that out. They're doing great things in the community in regards to workforce development. I want to thank, again, Sarah Mutinelli from the Young Singers Club of Salem for presenting today's national anthem. And as always, we wish to recognize our partners at Allied Video Productions, Capital Community Media, and then the Salem Convention Center that showcase their talents each month, put this event on, and host you here. Also to our Salem Chamber ambassadors, they wear the logo, Navy logo jackets and help make these events happen. We appreciate your service to the business community. And then to Cheryl Nestor-Wolf, past President Jim Bauer, and the whole Salem Health and Salem Health Foundation team, we thank you for your support today in sponsoring today's Forum Speaker Series luncheon. And then each month, the Forum Speaker Series luncheons are presented by our partners at Hagen Hamilton Insurance Solutions. Thank you to the John family for your support, to the Hagen Hamilton team, starring Matt Houston, Chris McLaren, TJ Sullivan, and Chad Neal. A couple announcements real quick that I mentioned earlier. Our nominations process has concluded for the 73rd Annual First Citizens Award Banquet. So occurring on Saturday, April 13th, just right upstairs, and will be that event. Thank you to Mountain West Center for Community Excellence and the Pioneer Trust Bank for serving as our presenting sponsors for the gala. This is a black tie encouraged event, and we'll recognize a new outstanding young professional, 2 distinguished Service Award recipients, and then Salem's 73rd Annual First Citizen. Reserve your seats now at salemchamber.org. And then next month, well, this one will be a doozy, I think. Please join us next month for a very important Forum Speaker Series luncheon, as we're going to host the candidates for Salem City Council and Mayor. We will gather here on Monday, April 18th from 11:30 to 1. We cannot underscore the importance of electing candidates who understand the importance of Salem small business community. I think that was pretty evident earlier this year with the payroll tax discussion, so this is very vital, and we encourage you to be here to hear what they have to say. Again, you can register at salemchamber.org. And then I want to give one last plug for Lena's legislative reception tomorrow, 4:30 to 6 at the Salem Chamber. You're all welcome to show up. A great opportunity to mix with some legislators. There's no cost, hosted beverages and hors d'oeuvres, as she mentioned, and this is greatly sponsored by Northwest Natural. We'll close today with our flower centerpiece giveaway. The selected attendee gets to take home this beautiful floral centerpiece provided by our partners at Ross Fresh Markets. Today's winner is Patricia Callahan-Bowman of Express Employment Professionals. Thank you, Ryan. Well, with that, thank you all for being here. Have a terrific afternoon. Avoid some snow.